So let's talk about the pain experience first off. So when we talk about the pain experience, we're talking about things like severity, frequency, location, and duration of the pain. What are their medical diagnoses? What is their medication use? And right off the bat, you can start conceptualizing from the patient responses you get, you can start conceptualizing how they relate to the pain experience. So for example, some people will come up front and be very detailed. They might have a handwritten or a computer-written document that sort of tells you when they take their meds, what the dosages are. And you'll have other people that will mispronounce medications, not quite know what they're taking, not know dosages. They'll tell you that, they'll say, well, I take that red pill. What is that called again? And so you can, right there, you're starting to conceptualize their degree of education and involvement with their condition. And also maybe over-involvement with their condition. Asking them their med history is going to be very important. I'll talk more about that later. But very few people show up. So the pain patients I see working at a tertiary care center are sort of the patients of I'm sort of the last resort, essentially. And that means that they probably are bringing a lot of baggage with them. They've been through a lot. And that affects the type of assessment that I'm going to do. Other people who are embedded in a primary care setting, their assessment is going to be very different because they're seeing a much broader range of patients. And so I just want to keep that in mind, that sort of where I'm coming from is this tertiary care model where I'm getting people who have a lot of different medical diagnoses and a lot of psychiatric baggage as well. So assessing pain. There's as Ted mentioned in his talk, there's, and I kind of, when I was starting out as an intern, the idea of a visual analog scale or a Likert scale to assess pain as a psychologist seemed, that's just wrong to me. It seemed too simple. And over time, I've really learned that these simple scales can actually tell you a lot of information very quickly. So visual analog scales, so scales that are essentially like a straight line with zero pain leading up to maximal pain, and people sort of indicate where they fall in that continuum, can be very fast and quick and tell you kind of give you a nice quick picture of what's going on in terms of how they judge their pain or evaluate their pain. The McGill Pain Inventory has been used really pretty extensively in research, and one of the advantages of that measure, for those of you who are not familiar with it, is it's essentially a measure of words that are pain-related words. And people respond, in terms of characterizing their pain, they will check off which words apply to them. Now, we can have words that have a very high sensory loading to them, like tingling, let's say, and other words that have a much more affect-heavy aspect to them. So, like suffering, or I'm blanking out on some of these words. But you can, using the McGill, you can kind of almost quantify where people fall on a bandwidth of, do they tend to explain their pain more in terms of sensory words or more affect-heavy words? So this all sounds very good conceptually, but in reality, for chronic pain patients, they're just amped on everything. So they'll have high sensory loadings and high affect loadings. So in a sense, in my experience, you'll pick up a lot of the same information just in talking to people that you will also get from the McGill. But if you're working in a more primary care setting where you kind of have a broader base of patients, then the McGill kind of becomes more appealing. And that's the other thing I want to mention as we get into talking about assessment. In sort of reevaluating and reading old articles and sort of conceptualizing what are some really effective questionnaires and forms to give people to assess pain. One of the themes that kept coming up again is the importance of the clinical interview. So using your clinical skills and relying on your clinical skills in the interview to guide the assessment, and using the self-reports then as corroborating data.